Even as the federal and state governments make plans to combat opioid addiction and deaths, Georgia ranks 11th for the most prescription opioid overdoses. Prescription opioid deaths increased tenfold from 1999 to 2014 in Georgia. And in 2015, the state saw over 1,300 deaths related to drug overdoses. 68% of them were from opioids and heroin. And that's just one of the addictions our guests are tackling. The opioid crisis is the issue at hand. Welcome to Issue at Hand. I'm Nwandi Lawson. According to the Georgia Department of Public Health, the number of opioid drug deaths nearly equals the number of Georgians who are killed in car crashes each year. It seems like every single week we're hearing more and more news about how the federal government is addressing this issue, how state agencies are trying to make a dent in it. And we have two guests with us today to try to help us make sense of this opioid crisis. We're joined in studio today by Dr. Glenda Wrenn. She's the director of the Kennedy Satcher Center for Mental Health Equity. It's in the Satcher Leadership Institute at Morehouse School of Medicine. And Neil Campbell is also with us. She's the executive director of the Georgia Council on Substance Abuse. I want to welcome both of you to Issue at Hand. I thought it might be helpful for our viewers if we would just kind of start maybe with a little bit of historical perspective. Because for many of us who haven't been working in this field, it appears that the opioid crisis appeared out of nowhere. But could that actually be the case? What has been your experience with this?
I went back to actually my testimony in front of the Georgia General Assembly 10 years ago, and I looked at my notes, and we were saying, we got to look out. We have a prescription drug crisis in the offing, and that was 10 years ago. So those of us who sort of swim in the deep end have been seeing this for a long, long time. And if I think about it, going back 30, 40 years, even before I got into recovery, prescription drugs were often drugs of abuse. I did that myself. I'm a person in long-term recovery from alcohol abuse. And what that means for me is that it's been 27 years since I've had my last drink or illegal drug. So over that time, I've seen the arc of different drugs sort of coming into fad or coming into having more and more of a particular drug being the focus. But what we've seen, especially with the opiates, that it's been growing over time.
Yeah. What have you seen as being some of the factors leading to this?
Well, I think one of the major factors is related to mental health stigma, which leads to a disparity in attention between things of significant public health importance being ignored. If you compare it to other public health problems, those would have an easier chance becoming a focusing moment, like the Ebola crisis, if you think about it. I mean, how many Americans did that impact? But how much did we hear about that when it was going on? So conversely, suicide has been an epidemic for years, and people get a little burnt out about hearing about it. That doesn't mean it's still not killing people every 14 minutes. And I think the same is true for substance use disorders, that from a public health perspective, it's suffered from a disparity in attention.
Well, so now there is a little bit more attention being cast with the federal government proposing that they would expand, Medicaid coverage for those who are seeking, treatment and recovery. What do you think about this particular moment in our history? Does it look very positive as far as the movement to kind of overcome these substance abuse issues?
No,
I see you shaking
we just
your head
got through with our Georgia General Assembly, and we had an increase in some of the funding, especially for recovery supports, which is a good thing. But there's not nearly enough. Back in 2009, services were cut by almost 25%. That's treatment capacity and prevention services. So we virtually have no state dollars towards substance abuse prevention right now in this state. That was all cut when the recession hit, and they've never put those dollars back. So no, we're not on the right track at all. We have, I often get quoted as saying our hair should be on fire. We lost more people last year in this country to opiate overdose than we did in the Vietnam War. Wow. In total. We lose between 3 and 4 people a day to overdose in this state. We should be screaming from the rooftops, as Dr. Wrenn said. If it was Ebola or some other public health crisis, we would be laser focused on that. And because it's addiction, we're not.
And I guess because when you think about Ebola, people are thinking, well, I might catch it. And maybe they're thinking about addiction that, it doesn't impact me. But what are you seeing in this current climate, Dr. Wrenn, as the government's taking attention?
I'm like a hopeless optimist. So I think I'm glad that, Neil takes her perspective, because we do need someone fighting every single day and saying it's not enough. But what I'm excited about is how much interest from non-traditional partners has come about as people have overcome their personal stigma, their internal self-stigma. They've kind of recognized that this is in their life, whether it's themselves or someone that they love. Chances are someone that's been negatively impacted by these problems. So that means there is potential for the private sector, for business leaders, corporate leaders who look at their employees and say, I wonder what % of my employees are calling out of work on Monday because they're binge drinking on the weekend. So I'm excited about that opportunity. Obviously, we do policy work, so we're going to constantly try to get equity as it relates to public health policy. But sometimes the best transitions in the field come through innovations that come out of the private sector.
So, between hearing about increased federal Medicaid funding and then the call for everyone to carry an antidote to opioid overdoses, I'm just curious to know, does this, in your experience, and you both have a broad range, does this differ from other drug epidemics that we've heard of in the past, the crack epidemic, methamphetamines? It seems like every 10 years or so, it appears that a new drug is rising up. Are we handling this differently? Have we learned anything from the past?
Yeah, I think opiates are tricky. I want to say it's very layered, because there are people who have, and I hate to use this word, but it's legitimate chronic pain, right? And they need opiates to manage that pain. Some people do. And I also think the way that opiates work in our brain and the cravings that occur when you stop are something that we don't see with many other substances. And so I think and the fact that the risk for overdose is so tremendous. Plus this other stuff that's coming in that is manufactured in China, that is some of the things that were developed to help with cancer pain are being used more recreationally. They're very, very dangerous. It's kind of like all the other drugs we've ever seen, but on steroids. It's just the people actually die from this in ways that they haven't been before. And we're seeing it in a different population, I'll just say it. We are seeing it in a suburban, white, upper middle class population. We're seeing kids dying, and that has brought a lot of attention. You have people who are decision makers and having their children struggle with this, and it's a lot of times the focus is not what it used to be when we think about crack, right? Even though Dr. Wrenn will tell you too, the use of cocaine and the use of crack is the same, even a little bit more in the white population, but we hear about it more, and the response to it is different for different cultures, and that's been a problem as well. What we don't hear about is that there has been a huge increase in the African-American population of overdoses and use, and so we don't hear about that so much, and we have to take a response that considers all of the cultural dimensions, I think.
What do you see?
I mean, one thing that I think is different, thinking about other drug epidemics, there's not like an antidote to cocaine. So we know the impacts that it has on the brain, very powerful craving impacts that make people vulnerable to relapse, but there's not too much that we can do pharmacologically, let me specify. Get on me. So there's not too much pharmacologically that you can do with those other substances. Whereas with opiates, and this is a blessing and a curse, there is a medication that we can use to reverse the negative impacts. There's no reason why people should be dying from overdose. That's inexcusable. We literally know how to prevent that from happening. So that's why you're seeing action there. Now, one of the negative aspects of that is that the other non-pharmacological community-based, person-centered, culturally centered modes of living a life of recovery. You can't do that with a pill. And, there's still that hesitation and inadequate funding of those types of solutions. But I'm a little split on it, because I do think that we're at a point where we need to really expand access to medically assisted treatment in primary care. There's not enough prescribers, and There's limits. What other medication are there limits put on how many patients you can treat with this medicine? This is the only medicine for which that's true with Suboxone.
Suboxone.
Yeah, Suboxone.
Okay.
So and it was recently increased, but still 200 patients. If you're living in an area, most places you'll have a few providers that are treating all the people because, I mean, that's also really an inequity, I think, from a policy perspective.
Well, it's pretty interesting right now to be addressing, from a federal perspective, the opioid crisis, but then a considerable number of states now are looking into whether marijuana should be legalized. Cities like Atlanta trying to at least decriminalize possession. And I'm wondering, do you see any connection between these drug uses, or are they completely separate in their impact and effects?
From the policy level or from a personal level? No, what you often see with someone who's using opiates is also using a lot of other drugs as well. So you see it together, whether it's alcohol or marijuana or even stimulants. People use both of those. So I don't think from the use level there's much difference. From a policy level, I think they have to be kept separate.
Talk a little bit more about that.
Well, I think that we too at the Georgia Council on Substance Abuse support decriminalization on a lot of levels. We don't think people should be locked up for having a preventable, treatable chronic health condition called addiction, right? But then I think when you look at a response to opiates, it's just it's that more complicated, I think it's just a more complicated issue because they can be legally used appropriately.
And what are you thinking about that as we have both of these things going on?
Yeah, I mean, I can understand why it might be confusing from a policy perspective, and there's also not always consensus, even among the science, related to marijuana and THC. So I definitely think they need to be kept separate. They're separate substances from a policy perspective, but at the level of individual people that are vulnerable to addiction, you often see them co-occurring as well as co-occurring with mental health conditions.
Well, so we've been talking a little bit about like what might be accessible as far as recovery or treatment, but what about prevention? How are you seeing that landscape in Georgia and in the work that you're doing?
I think you're starting to see funding from the top, from the federal government. They are paying for more prevention. Again, our state needs to support more prevention efforts. We need to fund that appropriately. We believe in a public health approach, which is there's a modality called SBIRT, or a treatment model, it's actually a screening model called SBIRT. It stands for Screening, Brief Intervention, and Referral to Treatment. And what it does is it asks people questions that are basically conversation starters in some ways. We've done this with people in high schools. At Marietta High School, we did SBIRT with their freshmen. And you have questions like, in the last 30 days, have you ridden in a car with anybody who's been under the influence, including yourself? And it's a yes or no question, and then you have a conversation about that. So that can act as a prevention, because some of the kids we screened said, no, I don't do that, I play soccer, it'll get in the way of that. And then some kids looked at us and said, yeah, I'm high right now. Right? So when you ask questions in a non-threatening way, and you're not trying to push someone somewhere, you're just having a conversation, they really will start to talk about it. And kids loved that. And we're trying to get that in more and more high schools.
And Dr. Wrenn, I know at Morehouse School of Medicine, the work that you all are doing is really family-based and community-based. Does that also impact prevention?
Yeah, and the public health model for prevention, there's really 3 different levels. There's primary prevention, which is preventing people from even getting on that path. Then secondary prevention would be like early intervention. And then tertiary prevention, where someone has an issue and you want to prevent negative consequences from use. So, I like to go as far upstream as humanly possible. So with our community-based parent leadership development program called Smart and Secure Children, it's a peer-led program where we mentor and train parents in leadership approach and positive parenting to promote healthy brain development in their kids, because adverse childhood experiences are one of the top risk factors for pretty much every negative health condition you can think of. So if we can prevent adverse childhood experiences, that is a form of primary prevention for substance use disorders as well. And then I think for secondary prevention, there are some interesting programs that are kind of happening around the country. One of them is Health Partners 180 in Tennessee, where they have an early intervention program for opiate-addicted mothers. Because what better time is there in the life of a person than when they're bringing a new life in the world? You want to help that baby. You want to take care of that baby. So it's a good time from that perspective, but also your endogenous opiates are also bumped up when you're pregnant and when you're kind of nursing. So this program does all the wraparound services that our current system doesn't support, helping you with your practical needs, with your social determinants like food, like, you know, filling out this paper, that kind of close contact. And they provide that, and they had some early results that show that they're able to decrease the total cost of care in the first 4 months of life for those children. And then they're not being born with neonatal abstinence syndrome. So, of course, there's a lot of work to be done, but we can't make that an excuse for not doing something. No matter where you are, there's something that you can do to act on to try to address this problem.
Well, I want to thank both of you for the information that you've brought to us today here on Issue at Hand. Dr. Glenda Wrenn from Morehouse School of Medicine, and I want to thank you as well. Neil Campbell is here with us from the Georgia Council on Substance Abuse. And when Issue at Hand continues, we're going to find out how a family tragedy is translated into the greater good. Issue at Hand continues right after this.
I wish I was in school.
If only I had a math test today.
Or a book report to give.
I wish I was in school.
I'll stay after class. I'll clean the chalkboard. I'll do extra homework. I'll skip recess.
I wish I was in school.
I wish I was in school.
I really wish I was in school.
School ends, but free lunches for your kids don't have to. Find your local Feeding America food bank for help. Together, we're feeding America.
On March 4th, 2014, Missy Owen received news that is really any parent's worst nightmare. She learned that her son had died from an apparent drug overdose. Missy is with us here in the studio today because, you know, Missy, you've really turned this tragedy into some means by which you can help others. Now, I can only imagine that it's not to say that this in any way replaces the loss of your son, but can you tell us a little bit about Davis and kind of the direction that you've gone now with Davis Direction in these years since he passed away?
Sure. Thanks for having me and allowing me to tell the story of Davis. Davis was the firstborn son. He was one of 5 children. He was second in the lineup after my oldest daughter. But Davis was a very, very bright child. He was an honor student, member of the National Honor Society. He was the editor-in-chief of the high school yearbook. He was Hall of Fame. He was a travel ball player. He was everything. He was junior class president, senior class president, gave the graduation speech to over 3,000 in attendance on his graduation day. And then a year and a half to 2 years later, he was found dead in his car of a heroin overdose.
Missy, that doesn't sound like the profile that we normally hear of a drug addict.
Well, it's not the profile that most of us think of as a drug addict, but if you look into their actual profiles, it's not uncommon with this opioid epidemic that we're experiencing.
Wow. So what happened to Davis?
There were some things just over between high school and college that were stressing him out. And as I said, he was very bright, so his brain just never stopped. It was one of those that was just in constant motion. And one night he went to the medicine cabinet looking for something as a sleep aid, and instead found an old bottle of Vicodin that had been left in the medicine cabinet that said may cause drowsiness. So he took that instead, self-medicating, trying to get to sleep. And he was one of those people that had the euphoric experience, as 1 in 10 people do, of taking an opioid medication for the first time.
And so there are people, as you're stating, that one time and then it becomes something that they really are now going after on a regular basis.
What I understand is that about 1 out of 10 people have a genetic predisposition to opioid addiction, and he was one of those people.
Wow. So since that time, and of course after your family had to, of course, go through the restoration process of losing a loved one, how is it that you came to Davis Direction?
Well, after he died, the family was just devastated, and it was such a needless and senseless death that we felt like we had to do something. And even as early as 2014, people just didn't publicly speak about addiction and what had happened in their families. Many of the coroners and medical examiners were still listing it as a cardiac arrest on death certificates. But we decided that it was important to us and we needed to be up front and come out and let people know what had actually happened to him and how easily it was to become addicted. So we started doing our research, and what we found through our research was that people can go to rehabilitation, they can go to incarceration, and they get sober. But 9 out of 10 of those people who come out of those refining,
The recovery
situations will relapse and go back out. 9 out of 10.
Wow.
So what we surmised with that was that the service gap is actually for aftercare. So that's why we decided to do what we did, and we opened the Zone, a 21,000 square foot building that helps people in recovery stay in recovery.
And how do you do that? What are some of the services that are provided?
We have a coffee shop, we have a thrift store, we have recovery coaching, we have 26 meetings a week. We have arts and crafts, music, a workout facility, we have a game room, we have pool tables, ping pong tables. We have places where people can socially connect and encourage each other and support each other.
Wow. So you've also been very busy lately with the work of trying to really get involved in this national discussion around a national opioid crisis. What has been the work of the Davis Direction during this particular time when we have this federal declaration of an opioid crisis?
Right. One of the things that we do that we've been doing since 2014 is to hand out naloxone to high-risk families or people who have high-risk loved ones. And we, long before the governor even made the standing order in the state of Georgia, we were handing out naloxone because of our medical director having written a prescription for us to hand out.
So for those who are not familiar with naloxone, tell us about what the impact of that is on opioid overdose.
Well, naloxone is actually the opioid reversal drug. So if someone are in an opioid overdose, you could give them naloxone and it brings them out of that overdose. It knocks the opioid out of the receptors and blocks it for anywhere from 45 to 90 minutes. And it gives them an opportunity to get to the hospital, get help, and prevent themselves from going back into that opioid overdose. It gives them a second chance at life. And, if Davis had had a second chance at life, he might still be here. So we're big proponents of handing out naloxone, and everybody should have naloxone.
And now the federal government, I guess the Surgeon General, has actually said that that's the case.
Last week, the Surgeon General called for everyone in America to carry naloxone.
So if we wanted to comply with that, most of us don't know, how would we even access this?
Well, in the state of Georgia, there is a standing order, thanks to Governor Deal. He mandated that every pharmacy in the state of Georgia be allowed to hand out naloxone, and he got the standing order, which is the prescription for any Georgian who wants that. So the work is done. You can get it through insurance or you can self-pay.
That's really interesting to know. I know a lot of the work that you're doing with Davis Direction as well has to do with prevention, ensuring that young people don't begin using drugs in the first place. What kinds of activities are you doing in that regard?
Well, we try to promote prevention through going into the school systems. We speak to elementary school students, we speak to middle school students and high school students. And then we print literature, we hand out our literature. Anybody that goes into the hospitals will see our literature. And this coming fall, we're having our first national conference called Building Communities of Recovery, where we'll be teaching other communities how to do what we've done here in Metro Atlanta and build a community of recovery.
Wow. So for those who want to get more involved in the work that you're doing, what's the best way for them to connect with Davis Direction?
www.davisdirection.com. And you can see what we're doing. You can come by and visit the zone. We love to give tours. The zone is actually run by people in long-term recovery. So there are opportunities to come in and make friends, make sober connections, and just stay well, having a great fun time.
So I understand you're getting ready to get on the plane and head to Washington for more of the advocacy work that you've been doing. What's your next stop?
That's right. I will be on the Ellipse, where the Christmas tree and the Easter egg hunt and those activities take place for the White House, and I'll be speaking alongside Kellyanne Conway and Debbie Hersman, who is the national director for the president of the National Safety Council.
Wow.
So,
you know, when you go around and you're raising awareness in this way and you're speaking and so forth, what do you hope is the actual mission? What do you hope in Davis's name really lives on?
that people understand there's hope for recovery. You don't have to live a life of addiction. There's hope for recovery, and people out there are willing and wanting to help others find that journey.
And I understand that Davis did have an opportunity to go into some recovery settings, but you saw that there were some challenges, I think, in some of the settings that are available now. What do you see as being some of the improvements that need to be made?
Aftercare. We're one of the very few aftercare solutions. When you go into rehabilitation, you come out, and aside from formal not so much aftercare, it is aftercare like intensive outpatient treatment and that kind of things, but voluntary aftercare where you can just go in and drop by to have a cup of coffee with somebody or play a game of pool or whatever you would like to do. It's your choice. It's not mandated.
So that sense of community is really what you're trying to build in the zone.
Absolutely.
Well, we thank you so much for bringing this to our attention here on Issue at Hand. Missy Owen is the Executive Director of Davis Direction, and we really thank you so much for your time. We also thank you for being part of the conversation. Don't forget, it continues online at AIB Studios, at the YouTube channel, as well as on Facebook, Twitter, and other social media outlets. I'm Nwandi Lawson. I'll see you next time for the next Issue at Hand.